Thank you for joining on today's webinar. My name is Meg Beyer. I work with the Managed Care Technical Assistance Center, and I am happy to be acting as your MCTAC host this afternoon. Just a few items of housekeeping before we get started. I want to encourage everyone, if you have any questions throughout the webinar, to chat them in on the chat box that can be found. The function is found usually to the right-hand side of your screen, or if you look on the upper right-hand side, that's where you can find the chat feature. We will be saving some time at the end of the presentation to review some of the questions that have come in. For questions that aren't answered, we take all of them and are hopeful that we can put together a Q&A document at the end of the presentation. For those who have not joined a webinar before that MCTAC has hosted, we post all of our slides and following the webinar, a recording of the webinar itself on our website. MCTAC's website is mctac.org. The slides from today's webinar are actually already posted there. So if you wanted to follow along on your own computer with your own slide deck, you could go to MCTAC's website and download the slides. With that, I want to thank our state presenters who will be joining shortly. They're going to kick off the slides, and they'll be running through the content today. So with that, thanks everyone for joining. We're excited to get started with our webinar, and right now I'm going to pass along to our state presenters to get started. Thanks again.
Okay. Thank you very much. This is Emil Slane with the Office of Mental Health, and we put together this webinar to really cover three main areas. One, we were getting lots of questions on the HCBS rates under HARPS, as well as some of the feedback we've received on the rates. So we wanted to give an update on the rates. The second area we wanted to cover is consolidated fiscal reporting for these new services. So we have a section of the presentation dealing with that. And then the third area is any intersect with state aid grants and guidance that we have on that. So as Meg stated, there'll be time at the end for questions. We'll try to answer as many as possible, and if we don't get to your question, we will, post all of these on our website. So, okay, just to talk a little bit about the new services, the next slide. We are going to go into the full scope of what we have coming out here. So in New York City, HARPS, the new managed care plan for adults, became operational in October, and individuals are eligible to get assessments for new services, home and community-based waiver services, starting January 1. And this new benefit package consists of a full array of HCBS services listed out here, including rehabilitation, recovery services such as psychosocial rehab, peer support, family support, residential support, employment. And the key thing there is, in order to receive a waiver service and bill under the HARPS, a recipient first needs an assessment to determine eligibility, and if eligible, a plan of care that identifies the services that the individual needs. So we continue to have updates on individuals that are being assessed and plans of care that are out there. So I think at this point we have more than 1,500 people assessed who received initial assessments in New York City that are eligible to receive services, and that number is starting to climb. And these same services are available for the rest of state HARPS, which went live July 1, so July 1, 2016. And individuals can receive assessments for these now, and then starting October 1, the full array of services would be available for rest of state. So next slide. Next slide, please. Sorry. So we wanted to, sorry if you can go back one, we skipped one. We wanted to talk about the mechanics of this. So the way that the new services are set up is the providers will bill managed care plans under new rate codes. And then the plans are responsible for billing eMedNI. So in the initial rollout of this, the dollars for the waiver services are carved out of the premiums. We wanted to ensure full access to this. We have federal resources and state resources put aside for this to support a ramp up of this, and we wanted to make sure that they were built outside of the premiums. So the mechanics of it is you are contracting with the plans, and you're billing the plans, but the plans are billing you Medney and making payments to the providers for that using the rate codes. So the key thing is that it's outside the premiums, and the commitment that OMH has made that will happen for no less than 2 years. So as you can imagine, we wanted to ensure full access to these services, so we didn't want to project and have any limitations by including in the premiums. And, for a minimum of 2 years, they'll be carved out, and it's really about a commitment until these get to maturity. So we'll be looking at these services as they ramp up and look at that 2-year date. Next slide. We have current rates posted on our website for the waiver services. So in New York City, because these services are live and some people are receiving these services as assessments ramp up and more people get plans of care, we have approved rates by CMS that are posted on our website. And for rest of state, we are posting the rate for assessments, which are a billable service effective July 1. And we will be posting rates for HCBS services for rest of state, as those become available in October. So if you go to these links now, you could literally see the rate codes and the fee schedules for all of these services for New York City, and we will continue to update them as the services become available for rest of state. If you could, next slide. So as we rolled out, we're 9 months into the New York City implementation, and as we rolled out the fees, we've gotten some feedback from providers on the fees and the assumptions and formal comments. And we've been looking at revisions to the rates for that, and we're going to go over those in these presentations. But so you understand the basic framework for the rates. The New York City fees and the downstate region, which consists of the counties listed in this slide, Nassau, Suffolk, Westchester, Rockland, Putnam, Dutchess, Orange, those are defined as downstate, and they receive a comparable fee to the New York City fees. Any other fees outside of the downstate region, what we've done on other OMH programs is we've used a differential of about 89%, and that's the framework that we have here as well that CMS has approved for the assessments. So if you are in the rest of state and you're looking to plan and model these services, if you are a designated HCBS provider and you're evaluating, rolling out this capacity in the coming months, you can look at the New York City fee schedule that is on the website, and you can, assume that the initial fees at a minimum will be 89% of those fees there. So we did get feedback in the initial 9 months of implementation, and we have request pending CMS review to revise some of those fees based on provider feedback and actual experience. So, but the key thing that we want everyone to understand on this call is that none of those rates become effective until CMS acts on it. So we are submitting documentation to CMS. We are exchanging with them. And so we're going to go over all of those rates. We showed you the links to the current rates. We're going to go over the rates that we are proposing, but those will require action by CMS. And then ultimately, whatever is approved will be posting to the website. So we're going to go over some of the areas that we're looking, we're looking to update based on actual experience and feedback. So next slide, please. Thank you. So, I think we have our key context on this slide that any rates require CMS approval, and we do have these pending changes, these requests for changes. There's really three areas that we're looking to change that we're going to go into more detail here. We're looking to make some modest adjustment to the fee assumptions. The crisis rates, we're looking to completely rebudget. That's an area where we believe the current rates are lower than the required resources to operate that program. We've received extensive feedback in that area. So that's an area we are requesting to revise, and we'll go over that. And then the third element is startup. We are engaging CMS in a discussion of applying a startup adjustment to the fees for the initial period as these services ramp up. So, you know, clearly from the first several months of experience, the ramp up of these services are slower than we originally anticipated, and we are making a case to CMS that a startup add-on is needed here. And we'll cover these in more detail. You go to the next slide. Okay, so just to give you context, one of the things that we are revising to the fee assumptions is we had an assumption for staff work weeks productivity that we used to calculate the fees, and it was originally assumed at 48 weeks on average, and we're reducing that to 46 weeks on average, which increases the fee, and that's based on you know, substantial feedback we received. And if that's approved by CMS, that would result in an increase to the HCBS fees by a little over 4%. So if you look at that fee schedule in the PowerPoint, you know, those fees will be 4% higher if approved by CMS and posted. So just a short reference here, we're also doing additional changes to the psychosocial rehab fee that we believe are warranted, and this would be on top of that adjustment of $1.5 per unit that we discussed later in the presentation. And then also the other thing we're just noting here is that the crisis fees crisis respite fees had already built in that 46 work weeks per year, but we are looking to completely rebudget it, as I stated, and we'll get into those details. So next slide, please. So in addition to this adjustment to the productivity of how many staff weeks are available in a year per FTE, we're also revising the off-site psychosocial rehab fee up by $1.51 per unit to recognize that the billable face time would likely be slightly lower than the percentage we previously estimated. So I think before we had assumed 60%, and we're lowering that to 55%, which is consistent with what we're using already for CPST, and that results in the $1.51 increase to the rate on top of the other 4% adjustment we referenced. So when you look at those two adjustments combined for this service, it equates to about a 13% increase to the fees that are currently presented on the website. So we believe that that's something that is warranted, and you know, again, we are working with CMS on the documentation for that, and expect you know, an answer in the coming months. Next slide, please. So on the crisis respite side, this is an area where we received extensive feedback, and we are proposing a complete rebudgeting of that model based on you know, extensive dialogue we received from providers in this area. And the fee that we're looking to change to would go up for the short-term crisis respite from $306 to $419, and for the long-term crisis respite from $476 to $649. So this is an area where we will, because of the magnitude of the change, we will have substantial follow-up with CMS. They're asking, I'm sorry, this is, everyone's pointing out, this is for intensive crisis respite services, you know, residential crisis respite. So given the magnitude of the changes to the model and the assumptions that support those changes, that is definitely an area that will have extensive follow-up in CMS, and we will keep you posted on the status of those rates. So next slide, please. And the last key area that we're looking to make adjustments to is including a startup adjustment. And what we're proposing to CMS is an approach where we would pay a higher fee in the initial periods as the system matures. So what we're trying to recognize here is that in the initial rollout of these services, which is ramping up slower than originally projected, the initial rollout of these services, require hiring staff, training staff, and then as you move from low volume to full capacity, more resources are needed to recognize those startup costs. So we're proposing a 50% increase until the system matures to 55% of full utilization for HARP enrollees, and that would phase down to a 25% add-on to a 10% until it eventually phases out once the system matures above 85% of capacity. So that would mean that if a service were paid $1, before a startup add-on was approved, that if CMS approves this startup component, the rate would be $1.50 until the system matures to 55% of maturity or full capacity. So as I stated in the beginning of the presentation, we have the New York City rates posted to the website. Those New York City rates are applicable to the downstate counties, similar to our other outpatient programs that define upstate and downstate. And so the New York City rates are comparable to the downstate counties. And when you look at those rates, the upstate counties would be 89% of that rate to account for cost differentials in operating in different parts of the state. And these startup costs would be overlaid on top of those fee schedules for startup, as well as the other adjustments that we're requesting be approved by CMS. Next slide, please. And that just basically covers exactly what I just said. I'm ahead of myself. So this just summarizes exactly the framework for the current fees, and we're giving you a preview of areas that we're requesting amendments. So if you want to plan and model for rollout of these services, you can use the rates that are out there to do that. But what we'll keep doing is, as we get action on our request, we will post status updates to the website so that you have the latest rates that are in the system that will be paid. So, okay, next slide. So the next area that we've been getting a lot of questions on are CFR reporting for the new waiver services. So we're going to talk a little bit briefly about the framework we've set up within the CFR for HCBS programs and the program codes that we've set up. There you go. Yep.
Okay, the new program types and the associated codes have been added to the CFR manual for 1516. The calculation of the units of service varies by program type and is consistent with the fee schedule. And the Medicaid services billed and paid under the HARP are to be reported under the new program codes along with the associated costs consistent with CFR reporting requirements. What has changed in the architecture of CFR in addition to the new program codes is that there is now a separate and distinct line for Medicaid managed care. So CFR 1, line 72, which was Medicaid, has now been split into two lines so that 72A is Medicaid fee-for-service and 72B is Medicaid managed care, and that cascades through to DMH, to schedule DMH1 and DMH2.
Next slide.
And there is a list of all the services, and they're in the 1516 CFR manual, and they're also going to be in the calendar year 16 CFR manual, even though the anticipated level of use of these would be probably very low. They're still there and available.
Great. Next slide.
And there is just a list with the units of service. There's a little more description in the CFR manual regarding how to calculate those units of service.
And I think the key thing here is there is a billing manual out there for all of these services, and that's on our website as well with the fees. So as you see here in the CFR, we're defining the units of services that can be reported and claimed for each of these types of new service categories. And the billing manual obviously governs the ground rules for billing for each of these services, and that's the key document out here. But we're going to talk a little bit about the framework that we set up within the CFR for cost reporting HARP versus non-HARP costs. So if we can go to the next slide. So what I want to lay out here is that we have a commitment that we want stability in this system. We want to rapidly expand these services through a new benefit package. So while we have some state aid out there supporting similar activities, we've made a clear commitment that OMH is not looking to reduce or touch any state aid as these services are rolled out. Our real intent is to expand capacity, and obviously, state aid grants support, much broader scope than just HARP-eligible individuals. But the questions that we're getting clearly are, how do you report these new revenues? Clearly revenues are tied to how we manage our state aid grants within the CFR. So we've created this separate category that you have to report your revenues under for these new HARP services. And what we're requiring is that you have to report the associated costs with those new services. The CFR requirement is, to basically use staff time and staff effort. But we've gotten some questions on this, and we will be issuing some more guidance on, exactly how these mechanics work. So the current CFR talks about, manual talks about how a time survey is traditionally used to allocate staff time. But, the key thing that we're looking for is that any staff time that's dedicated to these new services, those staff costs have to be allocated to these new revenues. But we're also trying to give flexibility here with the state aid to ramp up and develop these new services. So any time associated with non-productive, efforts, as well as startup costs, such as hiring staff and training staff, those are still allowed to be captured against the, the state aid grant. So we'll have more guidance out on that. But so the framework that we have set up is that any of the services being provided to non-HARP individuals and associated revenues and costs should be reported under those existing state aid program codes. During this initial 2-year period, it is appropriate that startup costs to expand capacity can be reported under the state aid grant. We expect that there will be gradual growth in underspending as direct services and costs associated with service provision shifts over to the waiver. When we looked at some of these state aid programs that do match up with these new services, on average, 30% of the people in these programs may be eligible for HARPs and may get a plan of care and get access to these services. And at some point, we are going to be looking at that data and looking at the productivity under the under the state aid grants to ensure we're getting value for those dollars. And to the extent that capacity is shifting over, we'll need those dollars to support the costs when our federal grants go away and these get rolled into the premium. But the key framework now is that we're looking for expansion of capacity and stability in the state aid grants. So what we're encouraging providers to do is to ensure that they're focused on efficient service delivery, that they're rolling out these new services that can be supported on an ongoing basis with these rates, and we're also acknowledging that that there's ramp up here that we're trying to support with flexibility on the state aid grants. If we can go to the next slide. One more. So in terms of the overall framework, we are committed to keeping the current levels of state aid grants in place for the first 2 years of HCBS implementation, and that's really to ensure program stability as capacity is expanded. As these services mature, OMH will phase out some portion of the state aid that previously supported individuals who transition to waiver services, and you're able to bill. So, but you have a commitment from OMH that as we manage any state aid reductions, we'll also look at your overall data to see, if you're addressing unmet need for non-HARP population, we'll leave some of those funds behind to address that unmet need. But the key thing is we'll be looking to make sure we're getting value out of any remaining state aid dollars in terms of capacity and people served. Just a technical note here that OASIS state aid funding doesn't directly map for any of these services, so there is no decrease in any state aid funding that could occur down the road. So the key takeaways we want to emphasize on the next slide is that we, as this matures, and we're saying two years at a minimum for this being carved out of the premium and for stability in the state aid grants. But once we get beyond that period and we start to see rapid expansion and maturity, that we will be examining CFR and PCS data to ensure that we're getting value under the state aid grants, and we may have to make some adjustments there. So ultimately, the state needs to continue to demonstrate value for its state aid. So if there are services that are similar on the state aid side to these new services we're rolling out, the direction that we're moving really is expanding the framework there so that we're documenting the units and value we're getting for non-Medicaid, dual eligibles, uninsured individuals, so that we can demonstrate that we're utilizing services effectively. So that's a direction that we're committed to moving forward in the future. Next slide. And the last thing that we want to stress in this presentation is that we do have requests to change these rates, but the effective date is uncertain. Once we get some sort of CMS response to our request, any changes to those rates would be prospective. And it is also possible that the rates that we presented in that presentation may not be the final rates that get approved by CMS. We have to go through extensive documentation to demonstrate the need for these changes. And in some areas, CMS may reject the case that we're presenting forward. But that's something that we are actively working on and committed to. And we're hoping to have more feedback on that in the coming months as we engage with CMS. So everyone knows we submitted these a month or two ago, and based on feedback and the initial rollout, and we've received questions from CMS that we're actively responding to. And that process normally takes a few months of documenting the responses to these questions that we're working on. So, but the other key thing that we want to stress is that plans are currently negotiating with the provider networks, and providers who are positioned to move forward under the current fees will obviously have a long-term advantage in terms of getting referrals, building capacity. So we would just stress that at the same time, delays in participation could result in lost opportunities. We have gone out there and actively received updates from every provider that was designated for all these different services, and we've asked the question, are you ready to accept referrals, or is your capacity temporarily on hold? And we could say the majority of the capacity is prepared to keep moving forward. The one area where you'll notice the most substantial changes in the rates is the intensive crisis respite, where the vast majority of the providers have responded and indicated that the model needs to be substantially changed to make it workable. So we do have providers that are continue to move forward in developing capacity, entering into contracts with the current fee structure, and we obviously want the most expansive network to make these services available for HARP enrollees, and that's why we're actively working on some reasonable adjustments to these rates. We will keep everyone updated on that. So we're going to open up the presentation with McTack reading some of the questions that you're submitting, and we will respond and use the full hour for that. And then any other questions that we don't get to, we will post on our website.
All right. Well, thank you so much for that presentation. This is Meg again, and I want to thank everyone who has already chatted in questions. We have quite a few to go through, but I do want to encourage those of you who might have questions to chat them in. We do have a little bit of time to run through questions today, and as Emil said, any questions that aren't answered, we will do our best to answer after the webinar and get a frequently asked questions Q&A document created from that. So with that, I'm going to dive right into the questions. Our first set of questions looks like it's geared towards billing and the assessments. So people want to know who is responsible for billing the assessment, and will this change once legacy billing ends?
Okay, that's a great question. Do you want to respond?
Yeah.
Doug
Sure.
Berman's going to respond.
Sure. The care managers bill for the community mental health assessment, both the eligibility and the full assessment. If you're talking about the 3 visits and up to 14 days from the first visit for an HCBS service provider to complete the individual service plan, that gets claimed as the regular service code. There's no separate assessment code at the individual HCBS service level. By the service provider, yeah.
Okay, thank you for that. Our next question, okay. Will there be a retroactive payment of these startup adjustments for providers already providing these services?
Absolutely not. I stated during the presentation, and we'll put this in writing on our website, we are requesting to increase these fees. Any approval or action on our request will be implemented on a prospective basis. We still strongly encourage providers to expand these services because we believe that providers who are out there developing capacity, taking referrals, that they have a strategic advantage in terms of increasing market share and developing capacity. So right on the last slide that we left on, we encourage that, participation if providers, can, afford to do it within the fees. As I stated, that the majority, more than half of the providers that have been designated in all these categories have expressed a willingness to continue to move forward under the current fees. The one significant area of exception is intensive crisis respite, and that's an area that we are engaged with CMS as our highest priority. But any adjustment for startup would be done on a prospective basis once we receive action from CMS.
Great. Thank you for that clarity. And this is actually a question about CMS. So do we have an estimate on the time frame for CMS approval of the new rates?
We do not have an estimate on the time frame. You have assurance that this is one of the state's highest priorities. So we are responding to the CMS questions in a timely fashion, and we expect that CMS will respond to anything we submit as well in a timely fashion. Typically, changes in rate approvals still take a few months, and so you have a commitment from the state that we will post updates to the website on the status of our request. And then ultimately, whatever appears on the website, if we get approval, we will post the new rates on our website as well as obviously put them into the system so that you start receiving payment at any approved levels once they are acted upon.
And just to add on to this is a little plug for MCTAC. Whenever the state has an update around things such as this matter, we definitely include them in our newsletters or email blasts that go out. So for those of you who are registered for this webinar and are not signed up for the MCTAC email listserv, I would encourage you to join just so that you can definitely get information as soon as it comes out, both from the state and from MCTAC as well. We send out any updates from the state through our email system, so I just wanted to offer that opportunity as well.
Thanks, Beth.
Okay. Of course, yeah. Next question, I think I might be able to answer this one. It's a question about the billing manual. Emil, was that one of the links? I was just going to say, I think it was a link that was included.
Well, well, let me just flip back to that slide. I know we put the fee schedule. I think that is the billing manual as well. Yes, it is.
Great. So for those of you who have questions, wonderful. Yep. If you go to the MCTAC website and find these slides, you can actually, it's a hyperlink, and you can just click right on there and it'll take you to the billing manual. Yep, there we go. Great. All right, next question. Is there a recommendation as to how to calculate occupancy expenses for HCBS for CFR purposes?
Okay, yeah, that's a question that we have received from a few providers, and some of the questions we've gotten talked about. Obviously, in the beginning, there's such low volume of these services that we would argue that it's not material in terms of getting into a level of complexity to try to allocate, other costs associated with these services. But clearly, you need to put in place some infrastructure to allocate the cost of that volume of services relative to your overall services. So the CFR normally talks about, a time survey for staff time. What we're going to be doing is expanding some of the references into the CFR to talk about other acceptable methodologies relative to level of effort. So what we're just trying to get at, that if one staff person served 50 clients and one of those clients is a HCBS waiver client that you billed for, that you would have to put 1/50th of that person's cost or staff time associated with providing those services against that other revenue, as long as you have a logic that tries to address that level of effort, you're complying with the CFR intent. What we are going to look to do is come out with some more general guidance on what's acceptable for these services in terms of allocation between state aid grants and CFR, to ensure that you see our commitment in terms of flexibility to ramp these services up.
Great, thank you. So this is another question actually going back to the startup funding that was mentioned earlier. So the question is, will the startup money be federal and reported on our federal audits?
No, all of the dollars are really through the Medicaid program. So, we've carved them outside of the premium to ensure full access to these services. And so you're going to be billing them like you would a Medicaid dollar, and you should report it, as Kathy indicated, on the Medicaid managed care line of the CFR. So it's Medicaid revenue.
Got it. And just again, through managed care. And we've gotten a couple questions about those grants. So I think some folks are wondering how to apply and where to go to apply for those.
Oh, so the grants are not they're not grants. Okay, the startup funding that we presented in this PowerPoint would be through enhanced fees. So we have a fee schedule that's out there, and what we've done is we've gone to CMS to say we believe that fee schedule should be temporarily increased as these services ramp up. And we've requested that in the initial period that these fees be 50% higher than the current levels posted on our website. So our justification for that is clearly there'll be hiring of staff, training staff, and in the initial stages of this, there'll be lower volume. So there is no application that will be required for that. Once the state gets some action from CMS on these startup fees, we will post what that action is. So we don't know if CMS will improve our request in its entirety. We believe that there is a logic for a startup add-on as you phase in these new services. CMS may require us to change the approach that we're requesting, and potentially even the percents that we're requesting. So we are actively engaged with CMS, but it is not a grant. No provider would have to take action on it to access those. Whatever rates are approved, the state will be posting them to our website, and putting them in the payment system to ensure that that's what you're paid at. So all provider, actions as you move forward, are really based on the rates that are out there now. Because anything that happens will be done prospectively.
Thank you. And just to give Emil a little bit of breathing time, because he's been answering tons of questions, we've gotten a lot of questions about HCBS, eligibility, who can provide them, where they can be provided. So I just wanted to encourage folks, if you haven't already visited, MCTAC's website does have an entire section of resources dedicated to adult behavioral health, home and community-based services that I would recommend you visit and familiarize yourself with. There's a ton of information there, just so that we can keep moving through some of the questions that are relevant to CFR and the rates that we're trying to cover today. But, thank you for reaching out about those HCBS questions. I would refer you back to the MCTAC website or any of the resources that Emil and the team listed earlier in the presentation, the manual and whatnot. Okay, next question. During the presentation, it was mentioned that state aid would remain static for 2 years. When does the clock start on these 2 years?
The clock starts from the implementation of the waiver services. So in New York City, it would be January 1, 2016, and the rest of state it would be October 1, 2016. And similar to the carve-out of the dollars from the premium, I think really the concept is, we're looking to see how these services mature, and the commitment. We have projected a certain growth and maturity of these services, which we believe will take place as capacity is expanded, as people get assessments and plans of care, and we'll be reviewing how that plays out over the course of the next 2 years. And then, obviously, as we look at state aid, we'll be having more details available on that as we go forward, and we would give way advance notice. But our overall commitment is to expand capacity. So we're going to be looking at the overall picture and making sure that those objectives are achieved before we take any action on state aid to move it over to the premium to pay for the cost of any services that have migrated.
All right, thank you. Okay. Again, a lot of HCBS questions coming in. Great, I'm excited to see that. Just another point of emphasis, I'm seeing some questions about HCBS providers and working with MCOs. Just to encourage HCBS providers, we do have a tool on our website. It's known as the Managed Care Plan Comparison Matrix, otherwise known as the Matrix for short. And on that tool, we actually have listed contacts at each of the plans for different programs and who people should be in touch with. So we just want to encourage HCBS providers to view and review our matrix tool to get the right contact information in order to work with the MCOs to become a participating provider. For rest of state providers, that would be as of 10/1, you'll go live with these waiver services for adults, and then New York City, you have gone live as of January 1 of this year. Okay. Sorry about that, Emil. I'm stealing your thunder. One more question.
That's great. No, please.
Okay. All right. So do we have any idea of if or when rest of state IT for the award for HCBS will be announced, or has it been announced already?
Okay, I think the question relates to our HIT contract we're putting in place for waiver providers. We do have a contract that has been submitted to the controller, and it should be executed shortly. And the vendor that we'll be working with for rest of state will be, working with providers through the public process, basically mirroring what we did in New York City, engaging providers of waiver services to basically involve them in this project to help expand their HIT capacity for billing and health records. So that should be, information should be out and available on that in the coming weeks as the new contract is put into place. So it is literally pending approval.
There is guidance already available on our website regarding if you received multiple grants related to IT and or HCBS. There was the adult HCBS startup funding. There was the kids IT startup funding. There was the OPWDD, OMH, OASIS behavioral IT startup grant that was provided via an RFP. And then this BHIT program. And so it describes what to do if you receive more than one and any combination of those four, as well as there's also a list of pre-qualified vendors. So if you are looking at what your future might be regarding IT, go to our website, see if your vendor is a pre-qualified vendor, then you're in good stead regarding the BHIT program. If your vendor is not on that list, you might want to inquire why they're not.
Okay. All right. I think here's our next question. So this is getting back to staffing for HCBS. If we are using existing staff to provide HCBS services, this individual is wondering how their FTEs should be spread across the two different systems of treatment services and HCBS waiver services. I'm not sure if that's something we can, oh, go ahead, sorry.
Sure, that relates to the CFR reporting guidance that we've covered, that we're basically saying that it's really based on level of effort of that staff. So we're saying you are obligated to report your HCBS revenues and the portion of time that staff is dedicating to, portion of time that person is dedicating to the HCBS services, and you could do that based on units or hours or time survey. So we're going to add more guidance to be clear that, you know, there are acceptable alternative methodologies besides just time surveys. And then any state aid funds that are freed up from those, you know, the fact that part of that staff person's cost is now covered from those revenues would be available to help hire new staff, train new staff, prepare for expansion. And that's really the intent beyond stability in the current system as we try to expand these services.
I think what we're trying to say is we don't, and especially in the early going, we don't want you to spend more money on a time survey than it would you're actually spending providing services. So we're trying to come up with a way for you to just reasonably allocate it at the beginning when there's such a small effort.
And we will, you know, through our normal CFR training process, we will make sure to cover this thoroughly with the CFOs and the analysts that work on the CFR for the provider agencies.
Wonderful. Okay, and one last question, I think. And again, for those of you who have chatted in questions that might not have been answered today, that doesn't mean they will never get answered. We do have a process through which we go through after each webinar, and we try and answer all the questions that were outstanding that we just didn't have a moment to answer. So I want to thank everyone for chatting in questions, and you can feel free to do so. I do think I have the last question, which is more just an area of clarification. So this individual is wondering if we can clarify that state aid is not the same as the startup grants that were given to providers. Is that correct?
That is absolutely correct.
All right.
The startup rates that we presented in this presentation, you know, relate to the fees paid for these services. We gave startup grants, which Doug referenced as well, for certain qualified HCBS designated providers, and that was to help in terms of, you know, start to build some of your HIT infrastructure. And then state aid really is for existing services that are out there where we're basically saying in some cases those existing services map to these new services. And we know that any HARP individuals are going to migrate to getting services under a plan of care. And either, you know, they may go to a new agency or they may stay with your agency and you're able to build Medicaid for them. So yeah, so there's different buckets of state aid and startup that we're all referring to.
Okay. Well, with that, I think we are out of questions for and time for the webinar. So I want to thank our state partners for presenting and all of our provider friends for joining us. Thank you so much for being on the call, and all of our partners in general who are on the call today. I know it's more than just providers. We have MCOs, we have our advocate partners. So everyone, thanks for joining in and texting and chatting in your questions. We appreciate it. So with that, I think we are done for today. Thanks a lot, everyone.
Thank you.